Good afternoon, everyone, and welcome to another webinar in the AJN series on important topics in nursing and healthcare. My name is Sean Kennedy. I'm the editor-in-chief of the American Journal of Nursing. Also working with me today is Christine Maffa, Dr. Christine Maffa, who is the senior clinical editor for the American Journal of Nursing. She also maintains an active psych mental health nursing practice and oversees our consulting clinical editors and ensures the accuracy of content in the journal.
Hi, everybody.
There you go. That's Christine. The program today will be carrying CE credit, and that information will be available at the end of the program. But you don't have to worry about making sure you have the link, because at the end of the program, we have everyone's email, and next week, early next week, you should get an email that has all this information, as well as some other resource information and information about webinars and other Wolters Kluwer offerings. So some housekeeping tasks, housekeeping duties, of course. If you have any technical difficulties, please use the chat box to write in what problem you're having. We have two very experienced technicians with us, Scott and Billy, and they'll be monitoring the chat box and will respond immediately to any problem and try and help you out. If you have questions for the speaker or the panelists, we ask you to use the Q&A box. If you can't get into the Q&A box, you can certainly use the chat box. We will be monitoring both of those. So while everyone is logging in and getting settled in, I'd like to take this opportunity to talk to you a little bit about the American Journal of Nursing. We are the oldest circulating nursing journal in the world. We are published by Wolters Kluwer Health in the Lippincott Lippincott portfolio, which is very fitting because Lippincott published the very first issue of AJN back in 1900. AJN has a long history of providing timely and important content nurses need. And in addition to providing information about professional issues and patient care, in the archives, which started in October of 1900, you'll find reports and articles of nurses navigating disasters, wars, epidemics, and social upheaval from the very beginning of the journal. Today, we turn our attention to the COVID-19 pandemic. In the last few months, we have been fortunate to see the rapid development of very effective vaccines. Yet, according to a December poll by the Kaiser Family Foundation, over 1/4 of those respondents overall said that they were hesitant about getting the vaccine. That includes 29% of healthcare workers themselves. So while those numbers have changed for the better, thankfully, many people still have some issues or hesitancy and worries about getting the vaccine, including worries about side effects, certainly misinformation about the vaccine. There's new variants that now people are questioning whether the vaccines are effective. Lack of trust because of the race to development and prior bad experiences with the healthcare system still pose barriers for many people. As nurses, we will be heavily involved in the vaccination rollout, and we need to be prepared to listen to the concerns of the community. And we, of course, need to be prepared with accurate information and speak to them with science. So we hope this webinar will help you do that. So today, before we get into the webinar, sorry about that, I have a little technical difficulty here. There we go. Okay. AJN is available in many formats, print, digital, and mobile. Years ago when we started, we were available at the end of the driveway in a mailbox, but now it's in every format you can imagine, including Ovid, which is an institutional platform. Many of you may be familiar with Ovid because it is a digital platform used by many research institutions, but there's also access to lots of other content on Ovid that's useful for EBP, QI processes, QI reports, and projects. So we hope you'll take a look at some of their offerings as well. So before we begin, I've told you a bit about us, and before we introduce our distinguished panel and speaker, I'd like to find out, who are you? It's always helpful to know who's listening into the webinars and if we've reached the audiences that we really want to reach. So please indicate in the box what your what role you play. Now, I realize that many of these are not specific to your role, but please check the closest one. So we'll wait a few moments until people have checked, and then we'll look and see where we are. Okay, so we can show the results of the poll. All right, there they are. So 71% no answer, that's interesting. Nursing instructors, nursing students, nurse managers. So we have to look at our poll next time to make sure it's a little bit more applicable, I guess. We can move that poll question. Okay. So this is what we'll be covering today. And you can move your box with the speakers' faces in it down to see the objectives. First, there'll be a short presentation by CDC scientists from the Vaccine Task Force. We're delighted that Dr. Routh was able to join us. And we've asked her to present the current best evidence that we know about vaccines and the development and information. And then we'll have questions for the presenter and a moderated discussion by a panel about their experiences and work within their communities in providing public health information. I'd like to now introduce the program participants. Today's presenter first we'll hear from is Dr. Janell Routh, who is co-deputy Vaccine Implementation Unit and from the Vaccine Task Force at the CDC in Atlanta. Janell graduated from the UCSF-UC Berkeley Joint Medical Program in 2004, and then that was followed by a UCSF Pediatric Residency Program. For the next 3 years, she practiced pediatric HIV and tropical medicine in Malawi, and then returned to the US in 2010 for Epidemic Intelligence Service Fellowship with the CDC in Atlanta. Her CDC experience has spanned food and water break outbreaks, cholera prevention in Haiti, and to her work in the Division of Viral Diseases as the team lead for acute flaccid myelitis and domestic polio. And we're very happy that she could take time out of what is undoubtedly a very busy schedule these days. After Janell's presentation, our moderator, Barbara Glickstein, will moderate the Q&A and the following discussion with the panel. Barbara Glickstein is a public health nurse and principal of Barbara Glickstein Strategies. She's a media strategist for Carolyn Jones Production on her several documentaries about nursing. She was also co-PI for the Woodhull Revisited project that looked at how nurses were presented in the media and found that nurses were only used as sources in only 2% of health news stories. She's also one of the authors of a qualitative study of journalists' experience with using nurses, and that's published in AJN in 2018. Barbara was a participant in Take the Lead's 50 Women Can Change the World in Journalism in 2019, and was a fellow at the Women's Media Center's Progressive Women's Voices program and a producer of Health Cetera, a podcast series on health news analysis and commentary. She was Director of Communications Media Projects at the Center for Health Policy and Media at George Washington University School of Nursing. And Glickstein currently serves on the board of Project Kesher, a global Jewish feminist women's advocacy organization. And I was very delighted that Barbara consented to do this. She's a wonderful moderator. Before I turn the screen over to Dr. Routh, I'd like to introduce our distinguished panelists. They are Dr. Kristen Choi, who's Assistant Professor of Nursing and Public Health at UCLA. This past summer, Kristen participated in the Pfizer Biotech Phase 3 COVID vaccine trial and wrote about her experience in JAMA Internal Medicine. It was widely covered in mainstream national and international news media, and she's made numerous radio and television appearances and has really been a very articulate advocate based on her experience. And so we're very pleased to have her here to talk about her role in the vaccination. In her day job at UCLA, she studies health service and policy approaches to mental health, trauma, and violence among vulnerable populations. As both a clinician and scientist, Kristen maintains a clinical practice as a registered nurse at a safety net psychiatric hospital in downtown Los Angeles. Also joining us today is Dr. Sheldon Fields, Associate Dean for Equity and Inclusion at Penn State University College of Nursing. He's also founder and CEO of the SDF Group, LLC, a health innovation consultant company. He has 29 years of experience in the health sector as just about in every role as an educator, researcher, clinician, administrator, consultant, health policy specialist, and entrepreneur. He's a well-known and respected HIV/AIDS prevention research scientist with a focus on young men of color. He's a lifetime member of the National Black Nurses Association, NBNA, and currently serves as the association's national first vice president and chairs its health policy and research committee. He's the founding president of the Greater New York City chapter of NBNA. We also have Dr. Blima Marcus. Blima is an oncology nurse practitioner in ambulatory care, an adjunct professor at Hunter College Bellevue School of Nursing from the City University of New York, my alma mater, and a public health advocate. She has published and lectured widely on increasing vaccine confidence in providers and parents of children. She's consulted for the CDC and the New York City Department of Health during the measles outbreak in 2018 and 2019. Blima is the founder of EMES, Engaging in Medical Education with Sensitivity. It also means truth in Hebrew. It's a nurse-led organization dedicated to providing communities with evidence-based information, health information, and undoing harmful misinformation. Her advocacy work has been featured in the New Yorker, the Wall Street Journal, and the Washington Post. And last, but by no means least, we have Dr. Gina Miranda-Diaz, who is a board-certified advanced public health nurse and certified contact tracer. As a New Jersey licensed health officer and former director of 2 health departments in the state, she informs the community in English and Spanish about culturally appropriate approaches to health and wellness while advocating for environmental and social justice. She has collaborated with numerous organizations, including the American Heart Association, and in March she became its spokesperson to educate Latinos in the United States and Latin America about COVID-19 related topics. For over a decade, Gina has been a member of the a member of the executive board of the National Association of Hispanic Nurses, New Jersey chapter, and is the past president. She has received numerous awards for her contributions to nursing and public health, including being named a fellow in the New York Academy of Medicine. So that's our very distinguished panel and our distinguished speaker. And now I will turn the screen over to Dr. Janell Routh, who will give us the latest information on vaccines from the CDC.
All right, I think I've got everything ready to go. Good afternoon, everyone, and thank you so much for inviting me to speak today on behalf of the Vaccine Task Force at CDC on vaccine implementation. It is a true honor to be part of such a distinguished panel. As the name of the webinar suggests, I hope this presentation will be part of the pieces that you all need to help build vaccine confidence in your patients and communities, really by communicating the facts about the current COVID vaccines. So I'd like to begin with a snapshot about where we currently stand with our COVID-19 vaccine rollout. As of today, we have administered almost 70 million doses of either Pfizer or Moderna. Doses are being administered in all 50 states, U.S. territories, and affiliated islands. And to put this into perspective, our annual Vaccines for Children program that does a majority of childhood vaccines in the U.S. delivers about 80 million doses per year. So we've administered almost 70 million doses in just 10 weeks. I'm incredibly proud of our federal agencies, states and jurisdictions, and partners who have contributed to this truly unparalleled effort. So preparing for vaccination during a pandemic has actually long been a priority of CDC and the US government. Multiple efforts have been undertaken to outline initial vaccine prioritization strategies, to gain public confidence and stakeholder input as to the priority groups for vaccination, and really develop guidance for allocation and targeting vaccine during a pandemic. Currently, there are 3 main types of COVID-19 vaccines that are authorized or are undergoing clinical trials in response to our SARS-CoV-2 pandemic. I just want to emphasize, and I'll probably emphasize this again through the presentation, none of these vaccines are a live viral vaccine, so none can cause COVID-19 disease in vaccinated persons. The first platform is the mRNA vaccines, and again, I'm going to talk a lot more about these in detail. These are built around an mRNA core and surrounded by a lipid nanoparticle that helps them gain entry into the cell. Both mRNA vaccines are now in use in the United States, and that started in December. They do have some complicated storage and handling requirements, but overall both have good vaccine efficacy, and we know that both are about 95% efficacious against disease of COVID-19 disease. This is actually a really exciting day today because the FDA Advisory Committee, or VRBPAC, is meeting to discuss another new vaccine candidate made by Janssen, or J&J, which is the parent company. Both this vaccine and another made by AstraZeneca are built around an adenovirus vector. The Janssen vaccine is a 1-dose vaccine, which is refrigerated, and the data made public this week suggests it's about 66 to 74% efficacious in preventing moderate to severe COVID-19 disease. We'll see what the FDA has to say about the authorization, and then over the weekend, the Advisory Committee on Immunization Practices will meet to develop recommendations for this vaccine rollout. So we're all anxiously awaiting the results of VRBPAC today. Given the fact that the J&J vaccine does have much easier storage and handling, it really could prove useful in many situations across the country. And then finally, there's the Novavax vaccine. This is a protein subunit vaccine. It's 2 doses, but storage and handling requirements are slightly less complicated. It is a refrigerated vaccine, and this is currently undergoing phase 3 trials in a number of countries. So, as I just mentioned, 2 vaccines have recently received this Emergency Use Authorization, or EUA, after careful FDA review. Pfizer, or BioNTech, is a 2-dose vaccine given at least 21 days apart, and then the second is Moderna, which is a 2-dose vaccine given at least 28 days apart. Both vaccines were tested in tens of thousands of adults from diverse backgrounds, including older adults and communities of color. Data from these clinical trials, as I mentioned, suggest that both vaccines are 95% efficacious in preventing COVID-19 disease, and that they do have favorable safety profiles, and we'll talk a little bit more about that in just a minute. One thing to note is that we don't currently know how long the protection is after receiving a COVID-19 vaccine, but there is ongoing work at CDC to help answer that question. We do recognize that there are many concerns about the safety of these vaccines because they use new technology, and they have the appearance of coming onto the market quickly. But I'd really like to reassure you that although these vaccines do use new technology, they were developed based on years of research. And we've actually been studying them for more than a decade now. Part of the reason these vaccines were able to reach the market so quickly was that we were able to capitalize on existing networks already in place to test these vaccines instead of starting from scratch. So the researchers that put these vaccines into clinical trials used existing trial networks, like those that study other medical treatments or vaccines, to quickly conduct these trials. And then another critical piece of getting these to market so quickly was really that investment in manufacturing, even before we had that efficacy data on either vaccine. The U.S. government and vaccine manufacturers invested millions of dollars to scale up vaccine production at the very same time that clinical trials were taking place. So that really greatly reduced the amount of time between authorization of the vaccine and our ability to get it into arms. Because of that great financial risk, this doesn't happen very often, but you know, we all sense the urgency of getting the vaccine quickly on board, and so this was why the government and the manufacturers took this particular risk. mRNA vaccines are also faster and cheaper to produce because they use ready-made materials to make the vaccine, unlike some other vaccines that require things like cell culture, which can take more time. And then finally, I think as you can tell, FDA and CDC really worked hard to continue to prioritize the reviews of the data that the clinical trials produced, again, in order to get these vaccines out quite quickly. So what are messenger RNA vaccines? These vaccines use a process that teaches our cells how to make a harmless piece of what's known as the spike protein. That spike protein is found on the surface of the SARS-CoV-2 virus. It's the little knobs that stick out from the surface. mRNA vaccines really do, they harness that process within our cells that we use to make proteins, and it uses those processes to make the spike proteins. After that protein piece is made, the cell breaks down the instructions or that mRNA molecule, and it gets rid of them. Our immune system then makes antibodies against that spike protein, and when we're exposed to the virus, they protect us from COVID-19 disease. So a few key pieces of information about these vaccines. Like all vaccines, these have been rigorously tested for safety before being authorized for use. And we'll talk more about that safety data in just a minute. As I mentioned, mRNA vaccines do not contain a live virus, so there's no risk to acquiring COVID-19 disease from being a vaccine recipient. And then finally, one thing that comes up a lot, so I wanted to mention it here, that mRNA molecule from the vaccine never enters the nucleus of our cell, so it does not affect or interact with our DNA. I know this has been a concern and wanted to make sure that everybody here understands that that mRNA molecule, once it gives those instructions to make the spike protein, is degraded quite quickly. So while these vaccines are incredibly exciting and certainly are going to help us control the pandemic, they're one of our tools, albeit an important tool in our toolbox. And so I wanted to run through a few considerations that we need to be aware of when thinking about vaccination and the ongoing public health recommendations for vaccinated persons. As I mentioned, limited information is currently available regarding how much a vaccine may reduce transmission in the general population and how long protection will last. We also know that protection from the vaccine is not immediate. So these vaccines are a 2-dose series, and you have to get the complete series. 1 to 2 weeks following the second dose, we consider individuals to be protected. So again, important to get those 2 doses with the same vaccine. So we do not recommend interchanging Pfizer and Moderna. You should get that complete series with that same vaccine. And then another point to make is that no vaccine is 100% effective. These mRNA vaccines come pretty close, but there will always be some people who get vaccinated who end up developing COVID-19 disease. We expect this. And it's just something to keep in mind. It doesn't mean that these vaccines are not effective if you hear about somebody who developed COVID after being vaccinated. And then finally, I want to emphasize, and I'll probably emphasize this again as well throughout the course of this presentation, vaccinated persons should still continue to follow all current guidance to protect themselves, their family, and others. So even after vaccination, we recommend wearing a mask, staying at least 6 feet away from each other, social distancing, washing hands, following the CDC travel guidance, and then any applicable workplace or school guidance that's set up in your jurisdiction. So let's talk about safety. The safety of these COVID-19 vaccines is really our top agency priority. And several the vaccines that are on the market and will be coming to market follow those same safety standards as other routine vaccines that we've had for years. Several expert and independent groups review the safety data from these vaccines before they are being released to the American people, and as well, we have rigorous safety processes in place after vaccination starts to take place in order to better understand those safety profiles. So I kind of think about it as a three-pronged system that pulls together this comprehensive strategy. First, we're using established systems to implement heightened safety monitoring for COVID vaccines. Secondly, we've actually developed new platforms that are leveraging other federal data sources, such as NHSN, the National Healthcare Safety Network, to complement existing systems. And finally, we know that it's very important that these data and analyses need to be clearly communicated to the public as we conduct these safety monitoring processes, really as soon as they're available to build trust in these vaccines. So this slide is really busy, but it shows you all the different systems that are involved in that safety monitoring process. We have two types of surveillance to help ensure the safety of these vaccines: an active surveillance process and then a passive surveillance process. Active is where we're really reaching out to persons who have been vaccinated to get information. And then that passive process is where we ask for reports to be submitted to a certain system so that we can review and track those. So a couple words about that, and we'll get into some more details. Our active surveillance is done by a program called vSafe, which we actually developed in response to the COVID-19 vaccine program. It's a new smartphone-based system, and it's an after-vaccination health checker for people who have been vaccinated. And I'll talk a little bit more about that in just a minute. Our passive systems include something called the Vaccine Adverse Event Reporting System, or VAERS. This is a national system that has been around for decades, and it collects reports from healthcare professionals, from manufacturers, and from the general public, and so that we can track adverse events as they happen after vaccination. Multiple systems actually feed into VAERS. So again, this is a system where reports are sent. So we get reports from Department of Defense, the VA, and NHSN, as I mentioned, all feed back into this VAERS system. We also have another set of large linked database monitoring systems that will continue to provide us with safety data when these vaccines become more widely available. This will help us think about vaccine safety in certain priority groups and then across the general population. So that vaccine safety data link is really a network of 9 integrated healthcare organizations across the United States that help us conduct active surveillance and research on vaccine safety. So let me just say a few more words about this vSafe program. It's, as I mentioned, a smartphone-based monitoring program for COVID-19 vaccine safety. It uses text messaging and also web surveys to check in on vaccine recipients after vaccination. Participants get vaccine text messages in a regular cadence up to 12 months after they've been vaccinated. And participants can then report in any side effects or health problems from the vaccine. Any clinically important events then get followed up with an actual phone call, and that person is able to take a report and submit it to CDC for review. So we're really reaching out to people who have received these vaccines in order to get more information to build a very robust database. I think now, gosh, over 4 million people have volunteered to participate in this vSafe program. It's something that as you are being vaccinated, you should be offered. And I'm hoping that this encourages everybody to sign up for participation. It is voluntary. So just a couple things. This slide shows some data we've actually accumulated from our vSafe program. You can see the most commonly reported side effects from both Pfizer and Moderna in the first 7 days after vaccination. And I'll just make a point here that side effects from vaccination are a reality of these two COVID-19 vaccines. And we talk about them because I think it is very important to give people this information so they know what to expect. There are no surprises. Pain is the most common at 70% for both vaccines, followed by headache, fatigue, and myalgias. And the majority of these symptoms, I'll just mention, are self-limited. They resolve in about 1 to 2 days after the vaccine. I like to point out, as I did with my parents when they received their vaccine, that these side effects are actually your body responding to the vaccine. So even though they can make you feel uncomfortable, it's a little bit of reassurance that you are producing those antibodies that we hope for. And then I would just make another point that for Pfizer in particular, we note that those side effects are a little bit worse after the second dose than they are the first. So again, as I mentioned, our passive reporting system is VAERS, which has been really the backbone of our early warning system for vaccine safety throughout the decades. Reports of adverse events that are either unexpected, those that appear to happen more frequently than we might expect, or those that have unusual patterns are followed up immediately, and we often will conduct special studies to better understand what we're seeing through these reports. So here are some data from the VAERS reports that we've received from both Pfizer and Moderna, and they seem to track very well with what we're getting reported into VSafe. Headache and fatigue continue to be the top side effects reported, followed by dizziness for Moderna, and then you can see on the right-hand side of the slide, fever, pyrexia, and chills for the Moderna vaccine. So another busy table with a lot of data points, but I'll focus you on the very last row, which shows the total number of reports into VAERS, just over 9,000 as of mid-January. And the information that really the majority of reports into VAERS were non-serious adverse events. 89% of the reports into the system we consider to be non-serious. Only 11% of the reports into VAERS were serious adverse events, and we define those as life-threatening illness, hospitalization, or the prolongation of hospitalization, disability, birth defect, or death. The reporting profile into VAERS really shows us, I think, that the safety profile of these COVID-19 vaccines is consistent with what we did see in the observed clinical trials, and that overall our monitoring efforts are reassuring, and that these COVID-19 vaccine safety profiles are really safe and effective to date. And just to note, these are the first data that we've seen from both systems, VSafe and VAERS, but we will continue to monitor vaccine safety as we move forward. So, you know, to start to summarize, I think this is a really exciting and historic time as we see these first vaccine doses being given to combat the pandemic. And I must say, when my parents called to say they'd received their doses, it was a really wonderful day. But our work is far from over. There will be challenges. I think we're all hearing in the news about the new variants and certainly vaccine hesitancy challenges in many communities. But I'm reassured that we are all going to be working together with our partners to find needed solutions to these challenges. And as I mentioned, vaccines really are one tool in our toolbox. There are others that we need to continue to take to help stop this pandemic and keep our family and friends safe. So here's my second plea to really adhere to CDC guidance even after vaccination with masking, social distancing, and hand washing. COVID-19 vaccine safety really does get stronger with your participation. So public health partners and healthcare providers, you know, we're really the trusted members in our communities, and our actions and words do carry weight. So my plea to you today, my ask is that everybody does get vaccinated, choose to get vaccinated when it's offered. Do consider participating in VSafe and help us monitor for any health effects after vaccination. Do share your experiences with coworkers, friends, and family. Again, I do think that people take our opinions very seriously, and so we can really act as vaccine ambassadors in our communities. So wear with pride your "I was vaccinated" sticker or button if you do receive those after vaccination. And so lastly, I'll just say a few words about Vaccinate with Confidence. So this is a national campaign that CDC has introduced to really promote vaccine confidence across the United States. And try to help with some of those hesitancy concerns that we've been seeing in our communities. We want this campaign to target not just the public, but also providers. I think, Dr. Kennedy, as you mentioned earlier, we're seeing vaccine hesitancy even in our provider community, so all the more important to get the word out. There are 3 components to our Vaccinate with Confidence framework. The first really aims to build trust by sharing clear, complete, and accurate messages about COVID-19 vaccine in collaboration with sort of a whole of government approach, as well as state, local agencies, and our healthcare provider partners. So hopefully this webinar today will be one of the steps towards that. The second aims to empower healthcare personnel, particularly by helping them to feel confident in their own decision, both to get vaccinated and then promote it to their patients and communities. The third really focuses then on how to engage communities in a sustainable, equitable, and inclusive way in order to increase collaboration. And this is closely related to that element about building trust. I think our distinguished panelists will be able to talk more about what's being done in their own communities, but we need to build that trust. And just making a final point that it's not an advertising, marketing, or communications campaign. It's really this cohesive framework to support health departments, healthcare providers, our immunization partners, and then our community-based organization partners and leaders to really promote confidence across the whole of the COVID-19 vaccine spectrum. At CDC, we've got lots of resources to really help with this effort. More be produced every day for selected populations, really with key messages and tools to help boost confidence. So I do encourage you all to please take the time to visit our website for information that you can actually use in your practices. We have toolkits for medical centers, clinics, clinicians. We have toolkits around long-term care facilities and homebound residents. We've got toolkits for community-based organizations and for the essential workforce, occupational health clinics, et cetera, to help them promote confidence across workplaces. Lots of things are available. So again, please do visit our website and use these tools that we've developed. All right, well, so I think with that, I have come to the end of my presentation. I hope you enjoyed it. Really thank you for your attention today, and I'm very happy to take some questions.
Thank you. Thank you very much, Janell. That was a great presentation, and I see we do have some questions, but first I'm going to turn this over to Barbara first to she has some questions I think that she wants to pose.
Biological Products Advisory Committee is meeting while we speak. No hot tips about how things are going or any breaking news, we're very happy to hear. But seriously, while this has been under review, there has already been concerns raised about distribution, as well as this hierarchy of COVID vaccines based on the efficacies, which include good vaccines versus bad vaccines, and whether or not, for the reasons that you stated, it has its use, we have these concerns. Can you quickly comment on that, on the distribution? Would it go into communities that may feel like they're getting the J&J vaccine and not Pfizer and not Moderna? And is it going to look as though it's being used again to discriminate against vulnerable populations?
Thanks for that question. I think I would say first that there are probably no good vaccines or bad vaccines, that the vaccines that we have in our armamentarium right now are all unique, and they all have different properties that I think can really contribute to their usage across a broad population. Each has its benefits and each has its challenges. So I think we all know the vaccines that are available now, the mRNA vaccines, we know they have high efficacy, but we're still waiting to see how they work in real-world populations. You know, the data we have are from these very well-scripted clinical trials. So it's going to be very interesting to see, do people come back for that second dose? Were the side effects prohibitive, and many people actually don't come back for their second dose? These are questions that we will still need to answer moving forward. we know that these vaccines can be very challenging to get out into certain populations. For example, rural communities have a real challenge getting an ultra cold product far from the hub where they're delivered. So, benefits and challenges to those. The J&J vaccine, as well, we know that the efficacy against moderate to severe disease is a little bit lower than we saw with the mRNA vaccines, but its efficacy against severe disease, severe COVID-19 disease and hospitalization remains quite high. This is a one-dose vaccine that only needs refrigeration. So could this be used in certain situations where we need to get vaccine out to communities who, again, may not return for that second dose? I'll point out that one dose of J&J is still more effective than one dose of the Pfizer or Moderna. So again, this is going to be an effort across every jurisdiction to think through how to use these vaccines to successfully vaccinate their population. And I think, again, no good or no bad, we'll just use them all for the unique situations that they're intended. Apologies, I don't have any updates from VRBPAC right now. As you mentioned, the meeting is ongoing as we speak. In the vaccine implementation unit where I sit in CDC, we have been preparing information and materials that once we hear the decision from VRBPAC, we'll be able to get out to our jurisdictional partners. So that's what we've been busy with while we're waiting the news.
I'm a nurse reporter, so I'm always looking for breaking news. Thank you, Janell. Do any of the panelists have a question? If not, I have one quick other follow-up. All right, my second and quick question is, you did mention around safety and safety issues that the public is concerned about. And Helen Bronswell at Stat News, who won the Polk Award yesterday for her brilliant reporting as a science reporter, raised the issue recently in a stat article, about this issue of incidental illness, that in fact, vaccinations probably aren't always tied to an incident that occurs after someone is vaccinated. I think we saw this around the issue of autism and childhood vaccinations, which I know you're an expert in. This context has really been missing from the public health messaging around the COVID-19 vaccinations. Do you think it should be part of the messaging?
So that's a great question. I think we are very much trying to message out what the truth about the side effects around these vaccines in order to separate them, as you mentioned, from incidental illness that might occur on or around the same time as vaccination, because we don't want people to equate the two. These side effects are really self-limited. So again, 1 to 2 days post-vaccine, people might feel a little bit uncomfortable, again, headaches, some muscle pain or stiffness, but these should resolve. And it's one way. There was a question early on in the vaccine rollout, how are we going to know whether somebody was experiencing side effects from the vaccine or whether they were coming down with COVID-19 disease? Right. And so that has something that has that we really tried to think through here at CDC and message the self-limited nature of the side effects. And so I'm hoping that message is getting out there. Would certainly welcome feedback about how we could do that better.
Okay, thank you so much. I'm going to move now to our panel. And again, thank you for sticking around if you can. I know that your day is busy and we welcome your contribution for the remaining time that you can be here. I wanted to start with some of these reports out of the Stat COVID Tracker, which yesterday reported there were 77,291 cases of COVID in the United States and 2,417 reported deaths. The total deaths are 508,000 people. I will say extraordinary people, to quote President Biden, who said it this week at the memorial for the 500,000 people who have died. I want to start by saying communities are not monolithic. So we will work to not overgeneralize about each community we speak about today on this panel. And before we ask why Black, Indigenous, Latinx, Asian, Pacific Islander, Native Americans, and other people of color distrust structures like the healthcare system, we should each ask ourselves, what have we done to give them reason to trust it? This distrust precedes the pandemic, extends to recommendations about the COVID-19 vaccine. Medical mistrust is not just about past legacies of mistreatment, but comes from people's contemporary experiences of discrimination in healthcare, from inequalities to access to healthcare in their facilities and treatments. So these populations have had to have a much more difficult time and unequal access to our care. And for too many people in these communities, these vaccines are not within reach, and you will hear more specifically from each of our panelists and how they are addressing them. Finally, I just want to say that most people's willingness to vaccinate falls on a continuum. From full acceptance, maybe some of you already in the community listening and participating jumped in on it. We know Dr. Kristen Choi was a member of the phase 3 trials, to doubt and to outright rejection. So how do you respond to a person who says, I'm not saying never, I'm just saying not now? And this category has been referred to as cautious skepticism, or as one person I heard say, it's not a hard no, it's a slow yes. So we're here to address how you as nurses can address vaccine distrust through authentic community engagement. I've asked each panelist to prepare a 3-minute introduction, and then I will go forward with questions. And I encourage the panelists to respond to each other as you hear things. And I'd like to start the discussion with Dr. Gina Miranda-Diaz. And Gina, would you just start with your opening comments, and we'll keep it brief to 3 minutes.
Okay. As you know, I have been very involved in trenching the Latino and Latinx community because there are so many issues with respect to, especially, I'm just going to focus on COVID for this moment. Historically, there are several issues that occur when you have some Latinx communities with language and the inability to speak English, the inability to understand, and even health literacy. And then we have another issue with legally being in this country and the concerns about having their information gathered into a system where they might be sought out or deported, or somebody will find out who they are, identify them. And then with this issue of trust or distrust, it makes it a tough ladder, a tough hill to climb, because we don't have enough people who are knowledgeable about this, and we are fighting what the World Health Organization identifies as an infodemic. So unfortunately, Twitter and Instagram and Facebook continue to be a huge barrier, in addition to people being unable to have access to these vaccines. I know there's been many issues surrounding the distribution because of the weather, but people have to know about it, and they have to feel that they're going to be safe when they get the vaccine. If they choose to get the vaccine, that they will be safe and nobody will be out there waiting for them to, because of their immigration status. And really just trying to give them the science, really breaking down and crystallizing the science to them is very important, and is challenging. Most of what I hear is it was made too quickly. I don't know if it's safe. I'd rather wait till everybody else gets one. And if you got the vaccine, why are you still wearing a mask? Or someone got a dose, why do we have to get a second dose? Did the first dose not work? So there's a lot of challenges, I think, for anybody, but especially in the Latinx community, we need more people who speak their language, who can meet them where they are in the community. And these are really huge concerns. In addition to making sure that they understand that this is free. I know there are some issues with administrative costs up to about $28, $30. And we need to direct those people to areas or to clinics or places where they can get the help. I'm very happy to say that Latinx people were well represented in these research, in the trials. So I'm very happy about that. And I'm engaged in a study that we're going to roll out very soon to get some assessment from a segment of the population to find out what exactly are some of the issues they're facing. But these are quite, there's quite a lot of them. There's all over the spectrum, whether it be in the United States and globally. We just had a leader tell somebody, a Latin American leader, tell people that they didn't need to wear masks anymore. So we're constantly fighting a lot of these misinformation, disinformation, and being able to educate people. In the past, we were able to go to places of worship. We were able to go to community centers, senior centers, and those kind of avenues have been a little bit less available. But I am collaborating with community organizations, community-based organizations, to get the word out, develop some information in Spanish that's easy to read and that has a lot of graphics, infographics, and we are also planning on, and we would like to formulate a phone bank of sorts or a helpline for those people who don't have access to a computer and cannot make an appointment to get to have a vaccine or be able to get a vaccine. Okay. So those are just some of the things that we're working on.
And I'll come back to you in a moment. I'm going to ask who isn't speaking to please mute, because we're picking up some background sound. I'm going to go to Dr. Kristen Choi next. She has a commitment at 3, so I want to be sure we get to her. And welcome, and thank you so much for joining us today, Kristen.
Hi, Barbara. Thank you for having me and for the opportunity to be a part of this panel. Just to kind of continue the conversation we're already having, I wanted to give a very brief background to my own experience with the vaccine and framing this issue around mistrust. I got the vaccine, the Pfizer vaccine, back in August of 2020 as a trial participant, which was well before many others did. And I had a pretty strong side effect reaction to the vaccine. When I had that reaction, to be totally honest, it really scared me. It took me by surprise. I had never had a reaction like that. And it really, even as a nurse who understands vaccines, sent a lot of doubt into my mind about what could be going on with this vaccine. So I think knowing that, it's just been really important to me to think about giving our patients and giving the public clear and accurate information, and trusting that they can handle, in some cases, complicated information. I think it's very important that we explain to people getting this vaccine how they work and why they work. Again, noting that this is mRNA, this is new, it's not the same thing as DNA, and these are the side effects you can expect, and here's why they're happening, here's what's going on in your body. I have found that giving that information to people can really help prepare them for what to expect and allay their concerns. As a nurse, I give flu shots really frequently. And so I know that in giving vaccines, sometimes we can really rush through those conversations. We can just get into the mode of going through an assessment and asking questions and going through the required statements, but not really taking the time to have a real conversation with the person sitting in front of us. And I think that for the COVID vaccines, we have to be really careful not to do that, and to make sure to ask people how they feel about the vaccine, what their concerns are, and to prepare them for what to expect and why. Since participating in the trial and speaking about these issues publicly, I've since been giving COVID vaccines in Los Angeles, and at this point have probably given hundreds of COVID vaccines at drive-in mass vaccination sites. I have had this conversation over and over and have found that many people, even those coming to get the vaccines, have questions and misunderstanding about what's happening and what to expect. And so again, as nurses, we're in a really good position to address these issues and to give people clear and accurate information. And again, just would advise everyone that it's important to approach this in a patient-centered way and talk with people openly about the concerns they might have.
Kristen, I know you have to leave shortly, so I wanted to ask you to address the counterintuitive notion that vaccine skepticism is pretty high among healthcare workers and around high among nurses. And particularly, we're seeing that Black healthcare workers, for instance, who have tested higher for COVID are less likely to want the vaccine. And sadly, we're seeing this in CNAs as well as home health aides. How do you think we should be addressing that better?
Sure. The low rates of vaccine uptake among healthcare workers and nurses are certainly a concern because we know that this population is at higher risk of occupational exposure to COVID. I think that for a lot of nurses, we are in many ways existing in the same information universe as the rest of the public. I think that we would like to think that all nurses have access to the latest research and information and are taking the time to read research reports coming out. But the reality is that a lot of people are getting their information from mainstream news, just like the rest of the public. And people who have been working in the pandemic, in many cases, very long and intense hours and with overtime, may not necessarily have time to be reading every research report that comes out and following this in very great detail. So I think that we need to recognize that nurses and healthcare workers are coming from a place of being burnt out and working extremely hard in this pandemic, and that they may not have had time or resources to get information as much as we wish they would. So, I would say to your question, Barbara, it's important that we get this exact same information out to our healthcare worker colleagues the same way we would the public. I think emphasizing how the vaccine works, why it's important, what to expect is something that we really need to prioritize. I have personally had conversations with nurses that I work with who have told me things like they are worried that the vaccine will alter their DNA. They're worried that it contains fetal tissue. They're worried that they can't get pregnant in the future if they get the vaccine. And so having these conversations with our colleagues is really important. And again, it's not something that you can rush. It's something that unfolds over time and many conversations and sharing information and taking the time to explore where people are coming from. In the cases, though, of all the nurses I'm talking about, in the end, they decided to get it. And so I think that we can do a lot to reach out to our colleagues as well as the public to address this issue of vaccine, just questions and confusion in many cases.
Okay, thank you so much. Next, I'd like to go to Dr. Blima Marcus.
Hi, Barbara. Thanks again for having me here today. My work on vaccine hesitancy began in 2018-2019 when New York State and the rest of the United States experienced the largest measles outbreak in many years. So in 2019, the World Health Organization stated that vaccine hesitancy is one of the top 10 public health threats. But I think it's also important to know that vaccine hesitancy and concerns over vaccines go back hundreds of years. And in 1905 there was a Supreme Court case that established that at times public health behaviors can be mandated at the expense of personal freedoms. And this court case happened because one gentleman did not want to get the smallpox vaccine in the state of Massachusetts. So these fears are not new. However, I think with the rise of social media, I think the misinformation has found a new way to spread really rapidly. And I think what's important is to remember that although misinformation is so prevalent, that's never the right way to get information. And so many people make healthcare decisions these days based on Facebook conversations, people in their inner circles, not necessarily finding great sources of information. And as nurses, that's definitely something I feel we need to make a better effort at doing, at disseminating not just good information, but also good ways that others can get information and empower them to do their own research and to look things up on their own. And the community that I've been dealing with primarily has been in the ultra-Orthodox Jewish communities. And some research has found that 75% of infectious disease outbreaks have occurred in vulnerable communities. This often means in communities of color, Black communities, Latin American communities, Orthodox Jewish communities, Amish communities, any kind of small vulnerable community. Very often, these communities are actually targeted by larger, well-funded anti-vaccine organizations that know how to really, strengthen the mistrust that may already be lying there. So what I've learned is that it's really important to have people from within a community be those advocates and those vaccine ambassadors and be voices for vaccines and endorse the scientific information that we know and have and give it over to people who need that information and are seeking that. What I've also found is that one of the biggest barriers to vaccinating is a lack of information. People often want that information from their provider, especially if it's childhood vaccinations, but pediatricians and providers don't often have the time. And I think one of the panelists mentioned that. I think Kristen mentioned that vaccination has become routine. We don't really spend the time having conversations. And that's where my work has kind of been informed. And we've been trying to make an effort to have longer conversations with parents or with people who have concerns and try to get them the information that they're seeking.
Blima, is your community's reaction to COVID-19 similar to what you experienced working in your community during the measles outbreak in 2018, 2019?
Somewhat similar. There was definitely a lot more concern because the Jewish community did have a large percentage that were affected by COVID and a lot of deaths due to COVID. So definitely a lot more concern. However, concerns about vaccines or even diseases often boil down to three main concerns, and that is the disease really that bad? What is in the vaccine? And is it toxic to me, or can it be dangerous? And finally, does the vaccine actually work? And those similar concerns that I've seen during the measles outbreak are present right now, where some people try to fit narratives to just resonate better with them, such as wondering if COVID numbers are real or if they're somehow inflated. COVID deaths, right? Did they die of COVID or from COVID or with COVID? People start kind of really trying to get to the nitty-gritties. And wondering if they still need the vaccine, if they've had COVID. So there are so many different ways that people are phrasing their questions right now.
Thank you. Dr. Sheldon Fields, thank you for, we're waiting on to hear from you about your expertise in working in this community.
So thank you for the opportunity to join you all. You know, first and foremost, when it comes to, Black and other communities of color, I really want to remind us all that in addition to the COVID-19 pandemic, we're dealing simultaneously, and we have been dealing with a pandemic of racism in this country that is rooted in anti-Blackness in this country's refusal to reconcile its very racist past. You know, the unrest that we all witnessed last summer, sparked by that led to the rise of the Black Lives Matter movement, to the witnessing of the insurrection on January 6th of our nation's capital by a white supremacist mob, all feeds into the narrative that tells Black people that their life matters less. So the question then becomes, why should I trust the government? And I do get that question a lot. You know, Dr. Fields, how is it they developed this so quickly when, they've been working on things like an HIV vaccine for almost 40 years and we don't have one for that yet? And so what we are doing through the National Black Nurses Association is what we do really well, is educating our communities, because they are multiple and they're not monolithic. We are in 35 states with over 100 chapters, but we have ears on the ground, and we are meeting people where they are, community by community, rural, city, large, small. We are everywhere. We are the voice of the Black nurse in America. And some of these communities are really dealing with historical trauma. And what we're doing is acknowledging it and helping them through it, listening, and giving them the facts from a trusted source. As nurses, we all hold that moniker of being a part of the most trusted profession. And we really do leverage that with the various communities that we work with. We are part of the Black Task Force on COVID that includes all of our historical Black medical colleges and universities. Our president, Dr. Martha Dawson, is on that and representing us at that table. So we're having discussions directly with the Biden-Harris COVID-19 response team. We are doing webinars such as this, whenever we're giving a platform to talk about, the work that we're doing. We're also ensuring the mental health of our nurses, because who takes care of the provider? We are working with companies that really are supporting a mental health initiative for our nurses called Reset, funded by the Kaiser Foundation, offering mental health assistance to our nurses, and really making sure that people, again, have the information at a lot of our chapters are holding.
Go ahead.
Can you hear me?
Finish that thought. Yes, finish that thought.
A lot of the chapters are holding their chapter to educate, the nurses one-on-one and really keeping them up to date. But it is also very factual because we are a trusted voice.
Great. If I can ask one follow-up question in reference, the February 19th opinion published in the Washington Post titled "Black Americans Should Face Lower Age Cutoff for a Vaccine." The co-authors are Drs. Uche Blacksop and Oni Blacksop, and they suggest that vaccine allocation address inequalities head-on across the country, that in fact, Black Americans should be able to have all access to vaccines. Do you agree with that?
I actually do, because we that the vaccine is not getting to Black and other communities of color at the rate in which we are at risk, and see it. And let's be really clear, none of us in the Black community is surprised by this. We saw it coming. And in a city like New York City, there was this huge disparity. And New York City has transportation, but yet you put these mass vaccination sites in big stadiums that that are near suburbs of Long Island in Queens, and then you wonder why people are not getting them. You send in vaccination teams that don't mirror the population in those communities. So yes, we need to get them at. It's an all-in at this point, because hesitancy.
Sheldon, I'm going to ask you, if I may, I'm going to ask you to hold that point, and I want to make an announcement because I'm watching the time. We're asking people if they have a question to please post it now in the Q&A, as well as in the chat if you're having trouble accessing the Q&A. And while that's happening, I'm going to go back to Dr. Miranda-Diaz for a question while we're waiting for questions from the participants, which has to do with communicating uncertainty. And not only have you addressed the issue of pamphlets being translated into Spanish that are not written with the sensitivity to the humility of the culture or the health literacy in some of the population, is of a great concern. And you've shared with us some of the ways that you're addressing it. And this might be a good question for all of the remaining panelists. How do we communicate uncertainty so that it's not a cause for confusion, but in fact there is uncertainty? So I'll ask you to answer that first, Gina.
Well, I try to set the example that I was vaccinated. I'm a nurse, and I am trusted. There are a lot of people, many people in the community trust us. Uncertainty has to be addressed by allowing us. First, we have to get a huge campaign out there. We have to get people aware, increase awareness, but we also have to listen to what they have to say. And we have to discourage, as my colleague was saying before, I think Blima, them looking for other sites or other sources. We have to let them know where to go to get good information, how to, and not listen to word of mouth or listen to information that is not valid. And the uncertainty is, just explain it to them very clearly what is going to happen, what they can expect. I think if folks know what they can expect and what you went through, they will be less, they'll be more trusting, and they might be a little bit more inclined to go ahead and get the vaccine. But it's just moving them in that direction by giving them clear information and realistic information and truthful information.
Thank you. Sean, I want to just check in and see if there are any questions. You're on mute, so unmute yourself.
That's always good. Can you hear me now? Okay, so we do have a lot of questions. Some of them are very technical, and I think only Dr. Routh could answer, related to some very technical aspects of vaccine production and mRNA vaccines. One question that I did see was about whether they are still technically not approved. It's my understanding, and Dr. Routh did allude to the fact that they're emergency use authorization. So emergency use authorizations means they are not formally approved by the FDA, but they are approved for emergency use because of the situation and the crisis that exists. They will still at some point go through the formal approval process. But right now that it's emergency use authorization. My other understanding of this also is that because they are not formally approved, they cannot be mandated. So that people who had questions about whether, one could mandate that the whole staff of the nursing home or the hospital has to get a COVID vaccine, that under emergency use authorization, they cannot be legally mandated. Christine, any questions that you want to bring up after searching your Q&A box?
Sure. Sort of piggybacking onto what you just talked about, but we know that they can't be mandated to get the vaccine, but can someone address the ethics of nurses refusing the vaccine or promoting misinformation that discourages others from getting the vaccine? And should they be censured in some way if they're doing that behavior?
Anyone on the panel? Oh, go ahead, Sheldon, please.
I want to say one other thing about that. The fact that they're not approved, I think we need to be very clear with people. They're still being tested. That's why if you have any type of side effect, you really need to report it because they're using that data. So I want to make sure people really understand the importance of reporting. The other piece is nurses are people too. However, we do work under a code, the ANA, our code of ethics. And you really should be using an evidence-based science approach to what you do, because that's who we are as professionals. And we really do take an oath to do no harm. But we're in a lot of murky territory around, First Amendment rights. So I think it's a slippery slope. But again, colleague to colleague, read your code of ethics.
I have a follow-up to that, if I may, which is addressing this misinformation and seeing nurse colleagues and other health colleagues who are putting out misinformation and encouraging people not to be vaccinated. For those of you who are on social media, how are you addressing that misinformation in that space? Are you responding on those? Please, Blima, go ahead.
Okay, so that's something I've definitely been watching and participating in for over 2 years. And I'm kind of going to answer both questions. There are a lot of nurses, not too many, but even one is too many, who are very anti-vaccine, and some who are anti-science and anti-mask, who are vocal on social media. And they're using the position of being a source of trust and being a source of a scientific background to use that misinformation. And many people take their advice seriously. So that is a very real problem. But to answer your question about engaging on social media, I can't emphasize how important it is to engage. And some people will say, well, why bother? Sometimes the conversation is so far gone in terms of sharing theories that are so conspiratorial in nature that you feel like it's useless to engage. But I think it's important to remember that on social media, you have no idea how many people are following a thread or reading a conversation, and allowing lie after lie to engage in conversation without breaking in and saying, hold off, this is false, and here's a good resource you can read that on, is very important for the lurkers who may be reading along and are just being shared false information, but have not been yet given a rebuttal. So any kind of scientific and respectful response that can, battle those pieces of misinformation, I find is really important.
May I ask you, when do you cut your losses when someone's completely unpersuaded about a vaccine's benefit And how do you do it with respect so you can continue building a trusting relationship with people? Because I have to admit, I'm not in the space that you all are at the moment, and respectfully want to be respectful of people. So Blima, how do you cut your losses? When do you stop? When do you just say, I'm going to work on people who are maybe I'm not a definite no, I'm a slow yes?
General, those people are our target audience. We never really focus on people who have really firmly held and entrenched ideas that are very foreign to science. However, when you're on social media, it's truly hard to know where people's belief is. And like you said, it's a continuum. So for the sake of all the people in the middle, that's how you just continue that conversation as long as you can go on without raising your blood pressure too high or getting, frustrated and maybe starting, mockery is very easy to fall into when talking to people who have vaccine concerns. And that sometimes prevents people from asking their questions, feeling like they'll be made fun of. So I sometimes make mistakes. My colleagues and my team on my initiative to each other will vent, but when we're engaging with people who have real concerns, you're right, it is so important to keep that respect and step back when you feel you can no longer engage in good faith and be useful to the conversation.
I see both Sheldon and Gina they were both nodding their heads and responding. Gina, go ahead. And then Sheldon.
Yeah, I certainly agree. I certainly agree. And I went to a business. Most of the business that I frequent do have Latinx folks. And as the young lady was talking to me about, how come it doesn't work, and my brother went, and I said, why can I bring you some information and I can sit with you and talk with you? And she was very willing to listen to what I had to say. She said, if you could bring it to me and show me and explain it to me, she would be willing to listen to it. So that's a great first step, because in our community, word of mouth is huge. Businesses live or die depending on word of mouth, doctors' practices. So yes, we are the most trusted profession in the country for the past 18 years. And that's a big thing. That's a big deal. And we have to use that. Sadly, in this state, less than 5% of the nurses identify themselves as Latina. And of that, I don't know how many of them are bilingual. I suggest probably half. So there is an upward climb. But anytime I get a chance to tell somebody who wants to listen, and I could sort of crystallize that or distill that to them, I'm happy. I'm a happy camper. Mm-hmm. But there are some people that just, they're anti-vax, they just don't want to hear it. And the messenger RNA is very, very difficult for people to understand as well. So it's sort of like, and trying to tell them that this isn't new, that SARS has been around since 2002. So it takes a while, but if I can at least bring them to that point where they're going to come to the vaccine, to be vaccinated, that's a win for me.
Yay. Sheldon, you were shaking your head through.
Black Twitter can be brutal and very confrontational.
Twitter can be brutal.
It really can. So you can go down a rabbit hole real quick. So I don't go there. I don't get upset. I try to maintain my professional composure, and I offer trusted evidence-based resources that have been curated through the task force that I talked about earlier. And you just sort of redirect people. You pop a link in, and you'll see, people can click and they can see for themselves. But I'm not going to take people's bait. I don't do that.
Okay. Do we have another question from our community? Sean, you're on mute. Oh, go ahead.
One of the questions was, and related to the mass sites and that they're gearing up. Sheldon, you mentioned the stadiums before, and I always wonder, seeing thousands of cars lining up, if that itself isn't a detriment to people wanting to go get a vaccination. And one of the questions was, what's your feeling about using historic HBUCs as vaccination sites?
So if historically Black colleges and universities have facilities, absolutely use them. Use Black churches and faith places of faith that have open parking lots and trusted entities. use the federally qualified health centers that are in a lot of these Black communities, and use Black and other people of color health providers. Leverage us to help you do that, you know, because everybody doesn't have a car. Everyone doesn't have that same privilege. And use mobile vans to really go into some of these communities and do some home visits. You know, we got to take this to the people. You know,
Absolutely.
The mass vaccination sites is only one way.
Yeah, but we also have to get the product, and I don't think they're getting the product. They're really identifying specifically who they're going to get the product to, because my friend and I wanted to go to, you know, these buildings, to go to sites and to administer, but if we can't get the product, and we can't do that, and so it seems like it's too small. Yeah, it seems like it's like a.
But the issue of pharmacy deserts in a lot of brown and Black communities is very real. So don't tell me we're going to do this through pharmacies, because you're not in Black and brown communities. No, you're not.
I read that 70% of pharmacies are in white communities.
Yes. Yes.
So the idea of Walgreens and CVS and I don't know who else is on the list. They're also very late to making this happen. If we look at West Virginia, of course, a smaller state, smaller population, local pharmacists, they were in and out of nursing homes and assisted living facilities very, very quickly. So local is the answer. I want to go back to another question from the community, if there is one. If not, I have several more from my nurse expert panelists. While we're waiting for that. Okay, go ahead.
I see a question. Sure.
Okay.
Someone brought up, due to the confusing messaging coming out of the CDC early on, it has bred some mistrust of things like, at first they were saying the public shouldn't wear a mask, and now they're saying everyone should wear a mask. People are using that as a reason to distrust the information being put out. And a backup question to that was, what do you consider a good site to send people to get the most detailed information, since some of them are sites are conflicting with each other?
Yeah, go ahead, Blima.
To address your first question, what I've been telling people is that we don't often watch science happen. We very often see the end result of scientific experiences or projects. But right now, for the first time for so many people, even for myself, we're watching science emerge in its messy, mistaken ways in which we backtrack, we learn more, we progress forward. And with that process, there needs to be an acceptance of understanding that as we learn more, recommendations change. And it really goes back to the, you know, the pyramid of evidence, you know, the hierarchy of evidence, right?
Right.
Best practice emerges when best evidence becomes available. So for example, when the recommendation was not to mask, that was before we knew that asymptomatic transmission occurred. There was a delay in learning that.
The aerosol. And that COVID
aerosol
is in the air. Yeah.
So as we learn more, those recommendations change. And it's not about dishonesty. It's about, as we learn, we get more information, and it doesn't mean that we were lying before or being ignorant before. You know, as you get more info, you dispense it, and people need to move with that and respect the process. And it's new for all of us. And I think that's where the mistrust and confusion stems from.
If I can ask one second, if I can ask the community to post what state they live in and what is the best site to go to, because I think your second question really is not a national question, it's really a local question. So please go to the chat room and chat space, not a chat room, and please put in your state so we can share that information. While you're doing that, I have a question for the panel, which is, can you give me an example of expressing cautious optimism? For example, we won't be back to the old normal post-vaccine, but how much better than now without the vaccine? What incentives are you providing? In other words, we heard from Janell Routh that in fact we must continue to be strict about masking, physical distancing, hand washing, and not being indoors in each state, that's also very different. So how do you express cautious optimism? Let me start with you, Sheldon. How are you expressing cautious optimism?
Look, within the Black community, you leverage the messaging of the Black Kinship Network because we believe in extended family. So if not for yourself, for the others that are around you. And we have close networks. And if you absolutely don't want to take a vaccine, then these are the things that you can minimally do to respect the community. Mask, wash your hands, sanitizer. But, think about other people, because welcome to the political determinants of health related to your last question. This is about politics. And in New York State, go to the New York State, Department of Health that has a much better website and always had a truthful website when the CDC couldn't because of the political determinants of health of the last administration.
Exactly. Thank you so much for making that point. Can I go to Gina and Blima before I go to the next question, or Sean, do you need to jump in here?
The only thing I was going to say was related to the social deterrents of health, and that now Don Berwick of IHI is saying we shouldn't really just be thinking about the social determinants of health, but the moral determinants of health.
That's
so
good.
It just seemed to be really related.
Gina, just quickly, what's one of the ways that you're giving cautious optimism to your community?
Well, looking at what we've been able to do so far, they're opening up houses of worship. They're increasing our ability to go to the movie theater, or to do things that we'd like to do. And now with the vaccine, even though we have to wear masks, I'm going to be able to go and visit my mother after almost a year. And that's something that gives me tremendous, just getting my second shot, I was thrilled. And so just letting them know that we are inching our way, and science is trial and error, and like anything else, and we are inching our way to a new normal until we have reached herd immunity, a new normal.
Blima, your cautious optimism for your community.
I used to use the term cautious optimist as my descriptor years ago on Instagram, so that was funny. Kind of echoing Gina, I have to be honest, in my work community, in my patient population, which are primarily underserved people in Brooklyn, they're the ones where I'm really giving them messages of future hope, of getting to a place where they can see their grandchildren, where they can feel less afraid. They're oncology patients, so many of them have isolated for over a year now, refusing to leave their homes except for coming into the clinic for chemotherapy and appointments. So they're all getting their vaccines. I've seen some questions from the community out there asking about patients getting chemotherapy or people getting chemo and being immunocompromised. The widespread recommendation is absolutely get the vaccine, because getting COVID is so much worse in so many ways. The fatality rate for cancer patients is close to 20 to 25%. So definitely get the vaccine. So for my patients who have really been hunkering down, probably more than anyone else in America, getting vaccinated, seeing signs of hopefully, a light at the end of the tunnel has been very, very helpful in helping their mental state, because they've really been suffering.
Thank you. Before I turn it back over to you, Sean, I just want to thank our panelists, and as well just talk to this community of incredible nurses who have been participating, and others here. So we know that racism is a public health problem. And in order for us to address structural racism that preceded the COVID-19 pandemic, that has heavily impacted those who got it and died from it, I want to ask you, how dedicated are you as a nurse to address this? Are we in it for the long run? How can we work towards dismantling racism and earn trustworthiness? Thank you for joining us today. And thank you, Sean, back to you.
Okay. Thank you, Barbara. And thank you, everybody, for your participation. I know Janelle and Kristen had to leave earlier, and I'll thank them in an email. One of the things that we haven't addressed, and Gina had addressed it a little bit, was the fear of undocumented people. One of the questions was from someone in North Carolina who said we have many poultry and pork processing plants, and there's been a lot of conversation about vaccinating this population, but because of fear of immigration, they don't access it. And before we close, I just want to ask, does anyone know of any information reassuring people that the vaccine is free and without the interference of law enforcement? Gina.
Well, I know that our new president has said that he would not allow federal agents to be anywhere near the vaccinating centers. People who want to get vaccinated do not have to reveal their immigration status. Yep. And we have to go where they are. They're going to have to rethink how we are doing pharmacies and this. They're going to have to let nurses who are practitioners who can get a mobile unit out there, put these vaccines in arms, since we are one of the most trusted profession in this country. We have to be very clear, and we have to say what we're going to say, do what we say we're going to do, and clearly recognize our own biases. Recognize your own biases, and be truthful to yourself, and then think beyond that, because we cannot live in this world. And to me, there was no place in nursing for, where do you come from and what's your immigration status. Poverty, your inability to speak English, your immigration status should not be a cause of death.
Thank you, Gina. Absolutely.
Thank you.
It's another example of the political determinants of health. That was a political decision of the last administration. And thank God we have a Biden-Harris administration that has moved on.
Well, on that note, I think we all can agree that it seems we are moving more quickly, that I love Blima's point about science is evolving, and while we had some misinformation, maybe some missteps in the beginning because we didn't know enough, we're learning more and more and more. Even those who are hospitalized are surviving because we're knowing more how to treat them. So the more we learn about this virus, the better we'll be able to make vaccines that combat it, institute treatments that work. We have the variants, but thus far it seems that the vaccines are working against the variants, and as Janell mentioned, that's something they're looking at carefully. But I think the answer after listening to everyone is to, we just need to talk to people, tell them what we know is true, but also let them know that we're still learning, because then they don't come back and say, well, you said this, you said that. And I think that's the most important thing, is to say, here's what we know today that works and will help. The masking and hand washing and distancing in 1918, that's what worked for the Spanish flu. And I think we know that we had a lighter influenza season this year, likely because of the masking and social distancing. So we're out of time. I just want to reassure people who haven't had their questions answered. This is recorded. You can access it later on and listen if you have the technical questions, to go back to Janell's presentation and listen to that. We will be looking at all the comments and questions that people have put in, and see what we can do in terms of either putting them out on our blog or answering them or getting information to you. I am going to end now just with a huge thank you for all this information. I think it was great. Somebody just posted and said this should be on national TV. It was a great conversation. And so if anybody's listening, feel free to contact us.
Right.
I want to thank Christine for helping out with the questions, and they were coming fast and furious, so it was nice to be able to have some help with that. And I'm going to close now and just say thank you, and I will put up the slide that has the information on the CE access. But know that next week, again, I'll say this, you will be getting an email that has the link to the recorded presentation, a link to resources, because Wolters Kluwer has a vaccine tracker resource and other information references. So you'll be getting all that information in an email next week, including the CE. So thank you once again. I'm going to share the CE slide, and everyone have a great weekend and stay safe.
Thank you. Thank you, Sean, for the AJN. Thank you so much.
Okay.